Good morning. Thank you very much for inviting me to present today. The title is Lung Survival Prediction Software with Contextual Justification. So the aim is producing or making a program that can predict the probability of a patient, how much is his chance to survive if he undergo radiotherapy when he have non-small cell lung cancer. To prove that this align with the theme of this conference of multidisciplinary, I will introduce myself first. So I'm a postdoc researcher in Ingham Institute and Liverpool Hospital. My background is computer science. So my PhD topic was actually analyzing keywords in social networks. My only relation to the medical field before starting this position was that I was sick and ill and injured before. I never studied anything related to medicine. However, it was the experience of my life when I joined this team in 2014. The team also involves oncologists, Dr. Shalini Vinod, Dr. Geoff Delaney from Liverpool, also many medical physicists, Gary Gauzet, Andre Decker from Mastro, Lewis Holloway and David Thowitz are the main investigators. Martin Carolan, Mike Bailey from Illawarra, Jörg Lehmann from Newcastle Calvary Mater, Gary Gauzet from Liverpool, and also there's a lot of computer scientists from Mastro and from Australia as well. So Matthew Field, Johan van Soese, Sean Walsh, and Tim Lestberg as well. So all of this needed to build this prediction model. First, we will introduce a background about lung cancer survival, the current common prediction models, the proposed model in this work, and the experimental results. One of every 5 Australian cancer deaths is lung cancer. That's why we choose lung cancer to be the subject of this research. For treatment and also quality of life, it will be good if we have a decision support system or a decision aid tool for the oncologist to decide whether this person should go radiotherapy and should he take a radical dose, a high dose, or a lower dose for palliative care only. Now with the current progress, scientific progress in medical imaging, in genetic science, and so on, the number of factors that contribute to survival increased and boosted hugely to the order of thousands of factors, while humans can consider only 5 to 7 factors when they are making a decision. There was a study that done in 2014 by Carrie Obrecht in the Netherlands that showed when several cases introduced to oncologists before, and the oncologists were asked what is the chance of their survival, the accuracy of predicting the survival was about 56. While when they built a mathematical model, a software to do the same prediction, the software did predicted with accuracy of 71. This is not because oncologists are inefficient or anything, just mainly because they depend on the randomized clinical trial as an evidence on making their decision. And the way the clinical trial works is that there is a huge selection criteria that filter the eligible population to only 3% of the patient, and they are highly selective. They do not have any comorbidities. They have to be in the good health conditions and so on. While in reality, oncologists are faced with patients that do not, of course, fit all of these selection criteria. So a computer-based decision support system will analyze the medical records stored in each hospital database without having these restrictions or these selection criteria. Then we can find many similar cases to the patient subject to the prediction now, to the new patient. And of course, when analyzing the similar patient records, there's higher probability that this will match the survival of this cohort. This was the main motivation of this project, and the project actually involves collecting data from several hospitals to building these prediction models. This investigation also did help, especially in the Netherlands, to do this experiment. So the first graph, in the top left, they did classify or split the lung patients in Maastricht to three groups: poor prognosis, medium prognosis, and good prognosis. Poor prognosis, where there are patients who have a very low chance of survival. They found that many patients with the blue line did receive a radical dose, suffer a lot of toxicity, while they already have a very small hope of survival. While, yes, with a good prognosis, we have still in the green line, there were many patients who received palliative care, while they have a high chance of survival if they receive the radical care. So they found that using this decision support system may help in modifying or correcting these numbers a little bit. The problem we face when building these prediction models is related to, of course, how the medical records are recorded. There's always a lot of missing data, and also they are scattered along all the medical centers or all the hospitals, and they are very hard to collect. Also, there is a legal and ethical obligation not to move this data out of the hospitals. So we need to implement algorithms and mathematical models that can build this prediction or this software without without moving the data out from the hospitals. And also, there is no decision, there is no literature review that says that a specific mathematical model or a specific algorithm is much better or outperforming the other algorithms in predicting this. So we need to try as many prediction models as we can to reach the optimal one. To do this, we need expertise in programming in the cloud, web programming, and the programming interfaces, and also the mathematical programming of artificial intelligence itself to keep sending parameters between hospitals without sending the data, and extracting parameters, mathematical parameters like this, theta, and so on, without extracting the patient information itself between centers, and until we reach a global model, which is the one in the top of the screen, that resembles all of these models in each hospital to keep this up. Of course, this expertise needs computer science beside, of course, the knowledge of medical physics before that. The output will be a software that is similar to this. You can find the software in predictcancer.org. You will find models for predicting cancer survival for many sites, not just lung cancer. There is some for, I think, cervix, head and neck, and so on, where the input should be the age. For the model that Maastricht built, the input was the age, the WHO, the World Health Status, or ECOG, the smoking status, comorbidity code, and tumor diameters. Then when you press calculate, the output should be something like this. The probability of this patient to survive receiving a radical radiotherapy for the next 4 years is 4.14%, and 5 years is 1.56%. The problem also with some of these models, the mathematical models that used to build this prediction model was called linear regression, and another one was built called support vector machines. The problems with this model is that oncologists usually tend to do not like using them, mainly because they are black boxes. Oncologists do not know why this program did make this decision. Maybe he's wrong. He didn't. This algorithm didn't follow the procedures and the medical knowledge that he knows, and so on. So he have every right to do not trust this decision. Besides, also, it's a decision support. It's for consultancy thing. It's not for replacing the clinical trial evidence or anything. It's just to give an extra information we needed. So the solutions that we propose in this work is choosing a specific type of models that can give this contextual justification. Instead of using linear regression or support vector machines, which are known by literature in computer science community to be now the top or the state of the art of the models, is using an old model called the decision tree. The decision tree are a white box, not a black box. It can give some knowledge like this. The end decision, which is, for example, with the dashed line, will be know that this patient will not survive because he have a big gross tumor volume and the normal forced expiratory volume and ECOG or World Health Status score of 1 or more, which means that if he have ECOG status of 0, he may survive. Then now the doctor can see, does this make sense to the incoming patient or not? So we have two scenarios here. He sees that this align with the current situation he has, so he can adopt this decision, or no, he can see that this patient actually health status is better than 1. Maybe he have a health status of 0 or so on. So then he has the choice of not adopting this decision and make more investigations and so on. Another thing this decision tree can, this is an actual, from the actual program, from the actual code that we did develop. Another thing that this decision tree can provide also, it will give the clinician the population or the number of, the sample size that was used to reach this decision. For example, if we have big gross tumor volume, the probability of survival written here is 29%. The probability of non-survival is only 71%. And it would tell him we made this decision based on analyzing the data of 38 patients. If we go, for example, for the GTV small, it will tell him that we made this decision based on analyzing the data of 105 patients. For one decision like the one in the middle here, it says that we made this decision that survival is 0 based on analyzing only the data of 3 patients. This is unreliable, so he can neglect this decision and go up to the first node and so on. The decision tree have been abandoned from being used in radiotherapy prediction, despite that it was used the first time in the 90s for predicting brain tumor metastases. Then it was abandoned because, as we said, supportive vector machine and linear regression did outperform them in computer science community. While now, in these 20 years, there were a lot of progress in improving decision tree accuracy. There are new algorithms now, like random forests, bagging, and pruning that improved the performance of decision tree. Besides giving also the contextual information of why the decision have made, this will boost the chance of using decision tree. The lack of communication between the computer science community and the medical community was the reason why decision tree was not used, and this was published in 2015 by Professor Kang in the Radiation Therapy Journal. Now, in Liverpool, we did implement a decision tree on non-small cell lung cancer patients. We used predictors of ECOG, world health status, gross tumor volume, forced expiratory volume, gender, and age to predict patient survival. The initial cohort was 4,686 lung cancer patients. When we filter according to what is missing data and patients that we have 2-year survival data for, patients that have GTV recorded, FAV recorded, and so on, we ended up only with 97 patients that have the complete data and satisfy this criteria, which is another problem of missing data that we are researching, conducting another research on how to solve this later. We tried also, we compared the decision tree against the other state-of-the-art models like supportive vector machine, linear regression, and neural network. We found that the accuracy of decision tree was 62%, supportive vector machine 62%, regression 63%, neural network 60%. So there is no significant difference in the performance or the prediction accuracy of decision tree against the other models. Decision tree also can still give us the white box or the contextual information of why the decision have been made. The conclusion is that there is no significant difference between decision tree and the other algorithms. This contextual information will motivate oncologists and give them more confidence in using the decision support tools. And is that collaboration or more communication between computer science and medical society will improve and utilize the use of technology more in cancer therapy. Thank you very much for your time.